Good afternoon. We're ready to get started on our AppFaithHealth101. We're glad to have folks with us today to be a part of this. We're going to get started. Several slides just to give some background on AppFaithHealth and kind of some detail about it. So you'll hear from me today starting off. Robin Fox, who's director of our care management, social work kind of stuff, discharge planning, all of that. I think I'm right saying all that. And then Melanie will also be a part of it as director of pastoral care and head of this program. So glad to have you with us today. See the first slide. Thank you. Again, glad to have you here today. AppFaithHealth is an update on our, well, this will give you an idea of what we're doing today. We've done introductions already, so we're going to skip that. And let's look now at the AppFaithHealth vision and mission. I love the word dynamic. That's part of our vision here. This is a dynamic partnership. It exists between local faith communities. Any faith community is welcome in the area is welcome to be a part of this. And we will partner with them, meet those communities at the point of their need and the point of their practice and their procedures, and work in that way. So we're not here to dictate who believes what they should believe. We're here to work with them at the point of their belief and their practice. And that builds on the web of trust and confidence and communication, all those things that bring together the strengths of our congregations with the strengths of our health system, so that we can better promote good health outcomes, better health outcomes in the community. We've set goals to equip congregation members to provide that best care. We have 3 tiers of involvement. Tier 1 is just simply our connection with pastors. Over 100 local pastors are connected on that level. And that gives us an opportunity to know who they are. They know us as chaplains. What we know is, as pastors, those folks are better equipped to provide deeper, more personal care than we can do with people who are total strangers until we walk in and meet them. So we have over 100 pastors at that level. We have a tier 2 level, which takes things up to the point where we can have members of the church to fill out a pre-permission form, if you will, that goes into their medical records. So if they come into the hospital, then our office is notified that, so-and-so from such and such church was admitted last night, and we know that we're going to call their pastor because we've got that pre-permission established. And that gets the pastor involved a little more quickly, particularly when the patient may not be in a position they can tell us who their pastor is. So we know because they've given pre-authorization on that. Tier 3 moves all of that from tier 1 and 2 up to a higher level, where those congregations agree to be a community outreach source or a community outreach center, where we can partner with them to do actual outreach in the community. Great outreach tool for the church. It's a great way for the health system to be able to get out into the community and offer a variety of workshops. I think we'll hear a little more about the different potential trainings that we've offered over the years, and we're always open to new ideas and suggestions as well. So there's training involved. There's the partnership that we offer. The assistance when a parishioner is in the hospital, we can get that connection going right away, as quickly as possible. And then we have access to community health nurse or community health resources. The hospital has an outreach person that we're going to partner with, a brand new position at the hospital that we'll partner with. And so it's just all kinds of partnership ideas to get information and education and training and connections established so that we can work towards better health outcomes in the whole country. Next slide. This is a list of our tier 2 and 3 partners. Again, 102 pastors across the high country are involved on tier 1, but these are the churches that are involved tier 2 and tier 3. This gives you an idea of kind of a flow chart idea of what we're about, and with the center of this process being the people in need. That's congregation members, but that's also people outside of any connection to a local church. Particularly churches on Tier 3 can do outreach to people in their own community who may be lonely, may be struggling with health issues of various kinds, and the church can then step in and be a partner with them. And they don't have to be a member of that church or any church. But it's the people in need that's the heart and soul of this. And then you see all the pieces around that. I'm the AppFaithHealth connector. Melanie's the director. We have had a steering committee working with this, particularly when it's getting established. Community health nurse that I mentioned, the congregations, the members, and community services, which could consist of a lot of different options. Right now, we've got 2 or 3 things going on with AppFaithHealth. Different programs that are working with us in different ways with different congregations. So that's a view of kind of the flow chart, if you will, of the work we do. Again, leadership here, Melanie, Robin, and myself. We do try to provide clergy incentives. Right now, the parking is not, it's something we have offered, but we don't now because we can't have spaces sitting empty with our limited parking because of construction. We may go back to that at some point. And we're open to ideas, suggestions of what may help us be a good incentive to offer local pastors for their connection here. And you see down the list there, providing training, providing opportunities, support for the parishioners, the members that are in the hospital. The congregation clergy role, we like each church to have a volunteer. Some churches choose not to. The pastor just wants to be the person doing that, but it's good to have not only the pastor, the rabbi, the priest, whoever that faith leader is, but also have a volunteer helping coordinate the program within the congregation. Again, 2 and 3 level tier members can register the congregation members. They'll be sharing of various kinds of health information and details and stuff that's going on at the hospital. We try to get word out on that, so we want to keep people informed. And then making sure that the parishioners have support throughout their journey, whatever that healthcare journey is. We want to make sure they have good support. Again, the unaffiliated folks, we have that option to reach them. One program that we have that we're able to do in some cases is a transportation program. And I think a lot of the folks helped to set that up, that somebody may be home and have a follow-up, post-hospitalization visit with the surgeon or the doctor, but they don't have transportation. So we have a whole process in place that allows to set that up, and we've got a good group of volunteers. We also welcome more volunteers, drivers, to be a part of that program. And then leveraging the religious health assets, all that our various congregations bring to the life of this community. And in our case, in the field of healthcare and concern and compassion, all of those strengths from those congregations we want to bring to bear in our larger community by, again, promoting better healthcare. And then just good interfaith collaboration. So important in our world today, and that's what we want to be a part of this program for folks who participate with us. Just some highlights here. Congregations, pastors, and the congregations will know when they've got a member in the hospital. They don't. I've told folks in churches I've served over the years that I failed mind reading when I was in seminary. So you got to let me know when you're in the hospital. I know Jim's a retired pastor, and others. If you don't tell us, we don't know, but at least through our process, we can let churches know when we know. And even if they're not in our system, if they tell us, we're going to make every effort to get in touch with that pastor. We do want that congregational and pastor support for the people. We want to give lay leaders good tools to improve their level of care within the life of the congregation. again, healthier, safer congregations, and congregations that will do outreach. We want to support that and encourage that through this program. And again, working together among the faith communities to promote that idea of better health outcomes, better health access within our community through the different dynamics of this program. I believe that's the last of my slides. These are some of the options that we offer today is AppFaithHealth101. We offer these one of our impacts of COVID is we couldn't do these, but we will get back to that point of offering these other different kinds of trainings and educational opportunities. And again, we are open to suggestions on what may be particular needs that we could help to address. The nutrition for the people. We have one of our partnerships this spring with AppFaith is they're doing a nutrition education program in some of our churches to help identify needs there and help, particularly for senior adults, to help them know, to help answer their questions and concerns and provide education information for those folks who are participating. And we have a congregational health survey going on in other churches where that will give us some data to work with. What are some of the concerns in particular churches, and are there concerns that are recurring in different churches? We want to be able to address this kind of list, or add to this list, as these needs are made aware to us through that survey. So, all righty, we'll turn it over to Robin.
Thank you, Larry. Thank you for being here today. Again, my name is Robin Fox, and I'm the Director of Care Management. I'm also the Director of Nursing for the Orthopedic Unit. So we want to make sure that the right door, the right time, ready to be treated. We want to make sure that patients get to where they need to be when they have a need. And so we're just going to go through some of those and what that looks like. So navigating a healthcare system can be very complicated, especially for people that aren't healthcare savvy or haven't been around it very often. And so we want to make sure that we educate our community on what's our healthcare system, what services that we have, and how that we can help, and who to call if they have questions. And oftentimes, I'm a nurse, I've been a nurse for a long time, and so we're really good about talking in acronyms and using language that maybe some people don't understand. So one of the things that I would encourage you is that if I start talking about something that you have no clue what I'm talking about, always ask. And I think that helps remind us healthcare professionals that, hey, we're supposed to be speaking the same language. So if we need to spell it out, or it just helps us to learn as well. So we're going to be talking about the different levels of healthcare and learning how the congregation can best support the patients that are in the hospital. So my staff, we do discharge planning. And so we really want to meet the patient where they are and identify what needs that they have when they go home. Because if they have a safe discharge plan, then they're more likely to be successful and not have to come back to the hospital. So we want to make sure, like, what equipment, what services did they have before they came to the hospital, and then what do they need to go back home. Sometimes people, they're really sick and they're too weak to go back home at first. So sometimes people will go to a skilled nursing facility to get some rehab and then are able to go home. But there's also services that can be provided in the home. And so we want to make sure that we identify those and get those for the person. Because a lot of people don't have somebody at home, they live alone. And so we coordinate all of this, the services, the equipment. We also assess for food insecurity. And so I've been surprised to, really my eyes have been opened at how many people seniors that are living on a fixed income sometimes are having to choose between healthy food and their medicine. And so we have a lot of resources in our community that we're able to identify for them. And I passed out a visitor guide, and in this visitor guide, it has a lot of information about our services. And so in a few minutes, there's a couple of things I want to highlight, but every patient gets one of these when they come into the hospital. And so in our system, we have physician practices, we have primary care, we have specialized services, we have, in the hospital, we have an inpatient physician group. So your primary care physician is not the doctor that's taking care of you in the hospital. These are specialized doctors that only work in hospitals. We have outpatient therapy, PT/OT speech. We have specialty care, long-term care, and then our goal is to connect the patient with the right level of care, no matter what that is. So maybe you're going home independent, but you don't have a primary care physician. So we're going to set you up with a primary care physician. Or you're going home with home health, or you're going home and going for outpatient therapy. And so whatever the need is, then we help set that up. And not everybody wants our help, but we do try to help everyone the best we can. And of course, everybody wants to go home. And so sometimes it's hard to, for a person to realize, I really can't do it at home. I need to get stronger before I can go home and be independent. So we also help identify when someone is terminally ill, either from a chronic disease or, say, cancer, and then maybe hospice is appropriate, and so we set that up for them as well. We do the education. We want to identify and help people to know when is it appropriate to call 911. And so this is just a list of things that we tell you about. But if there's ever a question, it better be safe than sorry. So sometimes there's things that you could get in to see your doctor and it would be perfectly okay to wait. But then there are some things like these things that you really need to call 911 and get help. And then these are some things that kind of categorize. So for regular checkups or health screenings, those are very important that we encourage people to do on a routine basis. If you have cough, cold, fever, lingering pain, just unexplained weight loss, those kinds of things, you can just call and get an appointment with your physician. And then there's some things that where urgent care can be helpful, and then of course the emergency room. And so now, in the COVID era, the emergency rooms are staying full a lot of times. There's some days when it's just full of COVID patients. So we're really trying to encourage people to listen to your body, and if something is just not right, try to get into your primary care physician and not put something off until it's so bad that you need to go to the emergency room and then you end up waiting for hours and hours. So that's some good advice. Insurance is another thing that we try to educate people on. And it can be very confusing, and they're all different. Anybody that's 65 years or older and has worked is eligible for Medicare. Along with that, it pays for doctor's care, hospital care, home health, skilled nursing facility. There's also a Part D that pays for your medications, or most people have a copay. But if your income is low enough, then your copays might be minimal, or you might qualify for Medicaid. And Medicaid is a program for those that have a low income, but also have medical problems. So I used to think, oh, anybody that was really poor could get Medicaid, but you have to be disabled or have some sort of problem along with having a low income. And there's an algorithm that the state comes up with, and for a couple, there's a limit, and like you can have maybe your income together is less than $1,800, and you can have $2,000 in the bank, and you can have one car, and you can own a home. So there's all kinds of rules that are constantly changing. So I won't try to explain all of that, but just knowing that there is some help. And so, for example, my mother is in a nursing home here, and so she has a chronic disease and is on hospice. But when she went, she wasn't able to pay for it. She didn't have any money saved in the bank, but she did qualify for Medicaid. So then Medicaid picks up the portion that hospice doesn't cover, which is the room and board. So a lot of times those different programs will work together to help. And always encourage people to have this Part D when they sign up for Medicare. Because if you don't sign up for the Part D whenever you enlist with Medicare, then say, oh, I'm a healthy 65-year-old and I'm not on any medicine, so I don't need it. So I'm not going to enroll in it. But then 2 years down the road, I get some chronic disease, say COPD, for example, and I need all these inhalers and all these medications. Well, there's going to be a penalty because I didn't sign up for it right away. So even though they may think they don't need it, the penalty is going to hurt them down the road. So that's something I would encourage. Oh yeah, replacement policies. Every year, Humana is great to hang out at Walmart, or they used to like lure you out for steak dinner at the steakhouse and try to get you to tell you how they're going to pay for all your medicine and they're going to take care of everything that you need. But what they don't tell you is they limit a lot of care. There are some things you have to need, like say you need to go to a skilled nursing facility for a rehab, then there's a pre-certification that you have to qualify for, and where Medicare, traditional Medicare would cover up to 20 days at 100%, this Medicare replacement might only cover 7 days. And then they're saying, oh, you're too good, you can go home. So those are some things that, or people think that they're signing up for a Medicare Part D through, say, Humana, for example. And so then they think they're signing up for the medication program, but really what they did was they converted from traditional Medicare to this Medicare replacement. And so we have patients, especially in January, they'll say, no, I have Medicare. But when we run their benefits, you have Humana, for example. No, I don't. I have Medicare. See, I've got a Medicare card. Well, you're issued a Medicare card, but then, so it's just, I feel like it's so complicated, and there's tricks that they play on us. And if you don't understand it, and I've been a nurse a long time, and this is my day job, and there's still things that I'm learning. So it is very complicated. So if we can ever answer any questions like that, then my number's on the slide, so that you can always call. I'm happy to help. But the other thing that I would mention is that if you do find yourself in one of those Medicare replacement policies, and some people like them because their medication costs are very low, a lot lower than traditional Medicare. So if you find yourself in that, then every year there's an open enrollment period. It's usually the middle of October through the first couple of weeks in December. And that's the only time in the year that you can change. But I have found a loophole that if you say, for example, you need skilled nursing care, and that plan is not meeting your needs, then there's an appeal process that you can do with Medicare. Now, you the person that has the insurance has to call Medicare and plead your case, and I have seen that overturned like the next month. So, but that's extreme situation. So I always say beware. Yeah, I know. So primary care is so important. It's important for people to get established with a primary care doctor and to really let that doctor know what your wants and wishes are, and they know you and they work with you to try to manage whatever issue you have. And then it's important to keep that relationship. And then if we have people that come from, other areas, some people that live in Florida part of the year and here part of the year. And so it's important that they have someone that they can see and that can treat them. We have our inpatient physicians, but, if you come to the hospital, you have a new diagnosis, they prescribe medications. That medication prescription is only going to be good for 30 days, and so you're going to need to continue to follow up with your primary care. And so a lot of times we see that as a barrier, and so that's why people get into these repeating cycles, is because they don't have a primary care physician. They run out of their medication, they get into trouble, and then they end up coming back. So that's very important. It's also important to be able to communicate with a hospital physician. And so, they round at different times of the day, but we always like to say that, if you want to, as a family member, want to talk to your physician or want to see what's going on, if you missed them, then, we can help to coordinate that conversation. Especially when it's, something serious, or, someone's getting closer to the end of their life, then it's real important to have that open communication. And I think it's on another slide, but we do have multidisciplinary rounds where the whole team really is meeting every day, pretty much, for some units. Med-surg units, we meet a couple of times a week, and the intermediate 3 times a week, and then ICU and the COVID units, we talk daily to determine what the plan is for the patient and how to meet that patient's needs. So, anything you would add to that? Okay. Well, we talked a little bit about physician follow-up, but it's so important that patients follow up after their hospitalization. And so, one statistic is that half of patients readmitted to the hospital within 30 days didn't see their primary care physician. And patients that are at high risk for readmission should see their primary care within 7 days of discharge. And we actually now have nurse navigators in our physician practices that contact the patient and make sure that they're getting in that window to come see their physician. And sometimes people don't see it as being important. If you don't feel good, then you have to get out and get ready and go to the doctor. But really, it's just making sure that things are going the way they should and you're on the road to recovery is really important. And then patients that say you come in for have a knee replacement or you have a gallbladder out, you might not have a follow-up within 7 days, but usually within 14 days. I think for the joint patients, they have an appointment within 10 days of discharge. And so we always try to make sure that we have clear instructions, discharge instructions for patients. And so I brought an example of our discharge folder. This is a folder that we give every patient. And so if you're helping someone in their home, then you might want to ask them where their discharge folder is. And so any kind of instructions would get put in this folder. And then their follow-up appointments on that, their list of medications is on that, when their last dose was given and when their next dose is due. So that just helps them to know, how to take their medicine. And, any prescriptions that we have given them are done electronically now. And so it would be on that, on the discharge instructions. So that patient discharge information note is very, very important. And so if you're helping someone in their home, then that main form is the most important piece of documentation that we send home with them. And it's called the patient discharge information note. Or we call it the PDIN. No. So if I start, nurse talks about the PDIN, you're, well, what are you talking about? So as we can see here, that with patients that are at high risk for readmission, I think about people with heart failure, people with COPD that are still smoking, have irritants in the air, maybe mold in their home, things like that can really exacerbate their breathing, make their breathing worse. I learned that I had a patient one time that kept coming back to the hospital. The doctor was, prescribing the right medication. The patient had follow-up. They knew how to use their inhalers and had a breathing problem, but then found out that they had a rodent problem. And so, so they had mice and they also had roaches. And roaches have this dander that gets emitted to the air and really can mess up somebody's breathing. So I had no idea that you would think a roach wouldn't have dander, but they do. So anyway, but 5 to 10% of healthcare spending, which is enormous in the United States, is spent for that high-risk population. It's typically poorly controlled chronic diseases. Diabetes is another one that we see commonly. And they may have basic needs that are unmet or significant barriers. So I think about people that live in low-income housing. Their housing isn't, how it should be. We see, we have a large homeless population here. So people that are in congregate living, like the hospitality house or things like that, that can be a real barrier for someone. And then the prediction is that by 2030, which isn't that far away, 20% of the population will be 65 plus and 80% will have a chronic disease. So hypertension, I have hypertension, I'm on blood pressure pill. That's a chronic disease. So we see as we age, we get more and more of those. So the ones that we really focus on for education with our nurse educator is the heart failure, COPD, diabetes, and heart disease. Someone that comes in with a heart attack. And we really try to focus and do some education then. Communication is so important. And, in your churches and your congregations, you know how important communication is. Well, in healthcare, it's so, so important. And so really, with this program, we're really trying to improve communication. 40 to 80% of medical information from healthcare providers is completely forgotten. Sometimes we wait till the last day. You've been in the hospital for 3 days. You're really sick the first day. You're on the mend the second day, and the third day, you're ready to get home. So the nurse comes in with a big stack of papers, and she's trying to explain all this stuff, and all you can think about is, did somebody let the dog out? Does the dog have food? Whatever you're thinking. And so, and then we see that 50% recall the information incorrectly. And then, as we age, we don't remember things like we should. Like I'm making lists now, more than I ever have in my past. Although I did read something the other day that between the age of 60 and 70 is the most productive time in your life. And so I'll be 61 on my birthday, and so that made me feel really good. Anxiety is another one that we see. People that you feel out of control, and if you're out of control, or you feel like you're out of control, it really does bring on more anxiety. And then two, how we deliver the message. So if nurses, I'm a nurse, and so I can say this, a lot of times we're telling you, you need to do this, A, B, and C, instead of really talking about what A, B, and C really is, the why behind why it's important to do A, B, and C, and really having a dialogue so that you're talking back, you're repeating back to me my instructions. So that does help patients to remember. And so that's another reason why a lot of times having somebody there to listen is so important. Another thing is, like, if a person's going to the doctor and maybe they're going to be getting some bad news, it's always good to have somebody go with them, even if it's just to be a scribe, because as soon as they get to hear the bad news, they don't hear anything else that the doctor or staff say. And so that's another area where your congregation could really be an asset to their members and help them to remember those things. We talk about advanced directives, and we help people fill out advanced directives. It's very, very important for people to talk about what their wishes are and identify who they would want to make decisions for them if they weren't able to, because we never know. I could be in a car wreck on my way home, and then my husband's going to have to wonder, well, did I want this? Did I want that? And so usually when those things happen, it's a very, very stressful time. And so there's lots of emotions. And so it's always easier, and we see it's always easier for families to be able to make hard decisions when they know that their loved one had said this, I don't want this, I don't want that. So there's different forms. There's a healthcare power of attorney, which we highly recommend. A durable power of attorney that helps someone to be able to work with their finances. A lot of times we see people that, an example of a patient coming in, they're really, really sick, and they know that they're going to probably have to go on a ventilator, and they don't have their affairs in order. And so then they're trying to hurry up and get a financial power of attorney done. Well, we can't do that in the hospital. It has to go through an attorney. And then you throw COVID on top of it, and it creates another barrier. And so then, their family's left with taking care and going through, a lot more red tape to manage after that person passes away. So that's very important. Okay, healthcare power of attorney is someone that you designate to make decisions for you if you are not able to make decisions for yourself. So I'll use myself as an example. So if I were to be in a bad car accident and be unconscious, be on a ventilator, and I can't make decisions for myself, then my healthcare power of attorney would be my husband, and he would have to make those decisions. And if we've done the paperwork, and he would know that I don't want a feeding tube, I don't want a trach, I don't want this tube in my neck to be able to breathe. If I'm not going to be able to make decisions and live life like I'm living it now, I don't want to be in a vegetative state, for example. So then my husband would make those decisions for me. I'm my mother's healthcare power of attorney. So I have a brother, he takes care of her finances, and I take care of her. So if my mom is not able to make decisions for herself, she's in a nursing home and she's on hospice, she still has capacity to make decisions. But if she were to get confused and not be able to make those decisions, then I would be able to make those decisions for her. And we've had those conversations, and so I know what my mom would want. And I know that she would not want to be in pain. That's the biggest thing for her. So, and dignity is another. She's afraid of being in pain and losing her dignity. So it's important to have those conversations.
Isn't there in the case where there's not a clear healthcare power of attorney,
Yes.
is there like a priority order?
There is, and I'm glad you mentioned that. North Carolina has their statutes that has a list of people that could make decisions if there's not a formal healthcare power of attorney. And that would be your healthcare power of attorney. I think number 2 is spouse, parent, siblings, and at the bottom of the list, I think there's 7, is someone that is, I forget the wording, someone that's an interested party. So here's an example. We had a patient in the last year or so who had no family, had no healthcare power of attorney, he had no children, he didn't have anybody, but he had a friend, and the friend was very involved with him, had helped him when he was at home, and so when it came to, he had a debilitating disease, and he ended up, I think, on the ventilator, and he was very, very sick. And he was not able to make decisions for himself. And so when the healthcare team met, and, we knew that really this person, he was very hospice appropriate. And so in looking at those statutes, his friend was, he knew him they had a very close relationship, and he was willing to make those decisions if they needed to be made. So sometimes we see that, but sometimes we see that there's nobody. And so, or there's families that maybe there's not been good relationships or bridges have been burned. And so then nobody can be on the same page. And so that really does create, it's just sad to see when things end like that. And so that's why it's so important to have those conversations and designate somebody. Healthcare power of attorney doesn't have to go through an attorney. It just needs to be notarized. So, and we are able to help with that, especially now that we are having visitors back. When COVID was raging and we weren't allowing visitors, we couldn't do that because hospital staff can't witness a signature for a healthcare power of attorney that's in North Carolina law. So we have to have a stranger. So, and all they're doing is witnessing the signature. They're not, they don't have to know anything that's going on. So we'll grab somebody in a lobby or something and have them come witness. So, it's helpful. Most forms, that's a North Carolina form that talks about medical orders for scope of treatment, and they use those a lot in skilled nursing facilities in our area. And so it's important to have those conversations. And then there's another form, it's called a Do Not Resuscitate Form, that sometimes we have if a patient wishes not to have CPR. And so if a patient's discharged home, then we encourage them to put it so that if somebody came in and found them, then they would know it. So I used to do home health, and so we would encourage people to put them right inside their front door. So I went to a person's home one time, and they had their door, and then they had like a glass window, and they had their DNR taped to that glass. So it's like anybody coming into their house knew they didn't want CPR. So, and then 5 wishes, that's just another, it's like a booklet, and it just goes through, helps someone to make those decisions about what they would want, what they wouldn't want, and that kind of thing. All right, I'm going to turn it over to Melanie. Thank you, Melanie. All right. So, again, my name is Melanie Childers. I'm the Director of Pastoral Care. And we're going to talk just a little bit about infection control concerns. That has become a bigger and bigger issue in recent years with COVID. But even before COVID, hospitalized patients are sick, and there's a greater risk of sharing their infections with visitors, and there's a greater risk of getting additional infections from the visitors. And so it works both ways. So these things are prevalent in healthcare systems. So we have to protect ourselves, and that also protects our families, the community, and the patient that we're visiting. So, and now with COVID, the precautions are even more important. All right. So during COVID, like Robin said, at one point we were unable to have any visitors in the facility. Fortunately, we have progressed from there, and so we now have, for our non-COVID patients, we have visitation from 7 a.m. to 7 p.m., 7 days a week, and each patient is allowed 2 visitors at a time. But those visitors can come and go, and when one leaves, a different person can come. So it's not like they have to, stay, and when they leave, that's it. So as long as there's just 2 visitors at a time in a person's room, then that's permitted. Also, visitors are now allowed to go back to the cafeteria and those kinds of things in the hospital. Clergy are allowed also in the non-COVID areas, and that does not count as one of the 2 visitors. So you just identify yourself as clergy in the front greeters desk, and they will give you a badge and send you on your way. All visitors stop by the greeter's desk in the front lobby. They're screened for COVID, and they get a bracelet and a badge. And there are exceptions that can be made. There are exceptions to any policy, right? So when we have certain end-of-life situations or some kind of crisis that's going on, a lot of times the house supervisor can make an executive decision. We can have these folks here even though it's 2 a.m. or whatever. We can have these visitors here. Right? So for COVID positive patients, we have opened up visitation on weekdays. So Monday through Friday, a COVID patient can have 1 visitor who comes either at 1 o'clock or 2 o'clock in the afternoon. So the visitors all gather in the front lobby, and a visitor coordinator kind of helps them all get to their right room, get them dressed out in the PPE, and helps make sure that they're safe and taking care of all of those specific rules that apply for COVID patients. Visitors cannot be COVID positive. They cannot be having symptoms of COVID, and they have to stay in the patient's room, fully dressed in the PPE. So they cannot take masks off while they're in the room. They can't be drinking drinks while they're in the room, that kind of thing. And then once they leave, they're done for the day. So they can stay up to an hour, and then they have to follow the protocol for taking off the PPE, and then leave the hospital from there and don't go visit other patients. So again, in certain crisis situations, we have had to delay or cancel the daily visitation just because somebody was in a crisis on the unit. But we can also, again, offer compassionate care visits at other times when there is a crisis or at end of life. Unfortunately, we do have a number of those. So we work as best we can to balance the need for safety with the need for patients to have family members with them, because that is an important part of their healing. And we know that, and we're just trying to balance out all of those different priorities. All right, so the most important thing we can do as visitors in a hospital is preventive spread of infection by frequent hand washing. You'll see these little hand sanitizers all over the hospital.
And all you have to do is stick your hand under there, just like you're asking for communion, right? I often think about communion when I'm doing this. And then I just bring it out in my hands until my hands are dry. And then I know that I am sanitized. So we use these before, between, after every visit. Of course, if we got something sticky on our hands, this is not good enough. We need soap and water. And there are some other situations where we need soap and water, but for the most part, using this hand sanitizer is one of the most effective ways of keeping down infections in the hospital. All right? So you'll also see some of these patties that are hanging on the door. When you're getting ready to go in to visit a room, if you see one of these patties, you want to stop, because there are special precautions for that room. And so there are gowns and gloves and masks. Now during COVID, we're all wearing masks anyway, so that part's taken care of. But this little precaution sign right here will tell you what else needs to be worn. And what we have found is that when a clergy and the faith groups follow this protocol, families are more likely to follow it as well. I remember one day, one of our Lutheran pastors was standing out in the hallway, completely decked out in his protective, personal protective equipment, waiting for his turn to be with his patient. And I just praised him for that, because it makes a difference. It sets a tone. It sets an expectation that we value this and it's important and we want to support it. So I'd like to, for us to practice that. Jim, I wonder if you would be willing to come up and put on some PPE with me.
Okay, sure.
All right, let you face the front here. Oh, face the front. There you go. All right, so the gown opens in the back, and it's got a head hole and sleeve hole. So put your head in there. Yep. And then find your sleeve hole. One size fits all, most. All right. There you go. Pull this down. I think it's all wound up here. There we go. Okay. And then you'll tie this around the back. Okay. Yeah, you can get it for you.
I'll get my sleeves and everything else on.
Yeah. There's a lot of stuff you have to work around here. Good job. Okay, now you got little thumb holes here.
Oh.
So if you can get your thumb in those, and then you put gloves on top of that.
Okay.
And you feel like you're going to be ready to perform surgery.
Okay.
All right. All right. Now, if this was a COVID unit, we would also give you a face shield that velcros around behind your head. So you would have a face mask on, or maybe two face masks, and then a shield going on top of that, which is most likely going to make your glasses fog up. Yes, they are. So you just go in and you can hold the hand of your loved one or whatever, and just have the visit. And then when you're ready to go, by the door there should be a trash can, and you're gonna grab right here on your gown and yank really hard. Yeah, yank it. Yeah. No, just break it.
Oh, like that?
Yeah.
Wow.
Like the Incredible Hulk.
Oh, wow.
Remember the Incredible Hulk? There you go. There you go. And then you turn the whole thing inside out with your gloves.
Yeah.
So let's see.
Oh, okay,
The glove would come off with your,
okay.
there you go. Yeah.
Oh,
And then
okay.
you roll it all up
Okay,
and throw it in the trash
Hmm.
and use the hand sanitizer and you're done.
okay,
Thank you
All
for
right.
being my guinea pig.
okay.
All right, and if there's any time when you have questions about this, the nursing staff is always there to help and assist. And if you're missing certain items that you need, they can help you with that. So feel free and comfortable to ask for guidance about that. All right, so we're going to shift now and talk a little bit about how we kind of assign roles in our congregations to help people once they get out of the hospital or if they've got chronic illnesses and things like that. As you all know, every person has a unique set of skills and gifts. I cannot cook worth anything. And so you do not want me to be preparing meals for people who just get out of the hospital. It would be a disaster. And I would be really angry by the time I got to that person's house anyway, because it was a disaster. Okay, so I am not good at cooking and food prep, but I'm pretty good at providing empathy and support to people, and I'm not bad at organizing things. So there are certain things I can do and certain things I can't do. So these are just kind of a short list of different ways that people might be involved in providing care, like aftercare, when somebody gets back from a hospital or from a rehab setting or something like that. And so for all of us, it's important that we know ourselves, that I don't go trying to cook up great food for a diabetic person when I don't even cook food for myself, right? So I need to know where I can best fit in and offer my skills to support the people who are in need. And faith leaders often are in a great position to be able to help assign folks to those roles because you know your congregants, you know where their gifts and where their skills are, and so sometimes you can kind of help kind of navigate them toward those areas where they could be most effective. A lot of people worry about what to say and how to act when you're visiting somebody in their home or in the hospital. One of the workshops that Larry mentioned was the caregiving conversations, and that is one of our most popular workshops. We have not done it since COVID, but we are getting ready to ramp those back up as soon as COVID gives us an opportunity. And this is a 2-hour training where anybody who is in the congregation who wants to be more comfortable knowing what to say and what not to say and how to help people just by being there with them and talking to them, that's a great opportunity for helping folks. And we've gone out to churches and done that. We've some congregations have deacons or pastoral care team or something like that, and they want that whole group to be trained in that area. We also have some pastors who like to participate. So it can be a really helpful kind of thing. Go to the next slide. This is just kind of a teaser for that training. The most important tool we have in helping other people is ourselves. And to be able to sit with another person who is suffering, and whose suffering you cannot take away is a gift. But it's also hard work. And it's not for everybody. So again, we want to assign ourselves to the places where we can be most effective. A lot of us, and I'll pick on nurses a little bit, nurses are trained to fix problems. That's what they do, right? That's what pastors do too, to a lot of extent. But sometimes there's nothing to fix. And it's a very helpless feeling to go in and sit down and try to talk to somebody when you can't solve the problem for them. And that's not actually what they need. What they need is somebody who can listen and be with them in a really powerful and poignant way. So that's kind of what we are talking about with our caregiving conversations training. All right, we'll go on. Yes. So when we talk about meeting congregations, members' needs, we can have a whole variety of ways that we do that. So if we have a patient who has family support but has been diagnosed with a chronic illness, are we going to do practical assistance or emotional support? What do you think might be most important for that? I think emotional support. It's a new diagnosis, and we may not know what kind of practical needs there would be yet. But I think just the emotional support of saying, hey, we recognize this is a change in your life, and it's not something you signed up for, and we want to be here for you and with you. And so providing that emotional support first. So if we have a patient who lives alone and because of an injury is experiencing significant life changes, practical assistance or emotional support? Or both. So yeah, this person could likely use both. Some congregations are very skilled at kind of moving in and helping a person through a temporary crisis when they don't have any family close by. And they can actually schedule themselves around the clock for a few days to be there with somebody. That is a beautiful thing. I love that when a congregation can do that. I feel like that's kind of what church is in a lot of ways. Some churches are not able to do that. And some churches have done this for so long that they overextend themselves because that's not sustainable long term, right? That's a good short term hurdle jumper, but that's not something that you can sustain long term usually. So we don't want congregations to burn themselves out trying to take care of a person whose needs are too great for them. So we also have to kind of balance out, okay, what can we reasonably do to support this person? And what kind of resources from the community can we bring in to support the person when we get to the outer limit of what we can do, right? Okay. So a patient will be going to a facility for short-term rehab or long-term care. In a situation like that, their practical needs are being met, right? So what they probably need is for not to be forgotten, right? So sometimes we have congregations who we used to have cassette tapes of worship services, and stuff like that, and bulletins. Now a lot of that can be done online, but notes and cards and reminders that, hey, we missed you, we're praying for you, we want you to know that we're remembering you. Those kinds of things are really important. So a lot of other kind of situations could present themselves. If you come to the hospital to visit somebody and you can't remember what room the patient is in, and you're not even sure of what their real first name is, what do you do then? This has happened. I had a pastor one time who came to visit someone named Bubba, and there was no Bubba on the census. And so the front greeters called me and said, this person knows how old the patient is and what road he lives on and all of this stuff, but he doesn't know his name. And so I figured out who it was and went and asked the person. He was like, well, I called my pastor to come over here. So a lot of times chaplains can run interference on those kinds of things and help smooth that over. Sometimes these days you can just call the patient directly and say, well, what room are you in? And that would solve the problem. If the door is closed when you get there, it's always important to knock and to be respectful that this is the person's only privacy that they have. And sometimes in the ER, it might not even be a door always, and some of the doors are glass. So we want to respect that privacy as much as possible. So we will always want to knock and ask if it's an okay time to visit. A lot of times we have to psych ourselves up. We come to the hospital and visit somebody, and we're all ready to get that done. And then if the person is sleeping or out for a test or something, we feel defeated because we haven't done what we came to do. But sometimes the best care we can give somebody is to allow them to sleep. And so it's always nice to just bring a little card with you or something so that you can leave it for them in the event that you aren't able to see them. Sometimes the family member will be in the room even if the patient's gone, and you can provide support that way. So, if there are lots of machines beeping and you aren't sure if that signals an alarm, please reach out. It's better to be safe. So go ahead and reach out and say, we've got these alarms, we can let the nurse know so that they can respond. We've already talked about the big caddies on the door, and we know what to do with those. And sometimes there's a sign on the door that says the patient is resting, please do not disturb. And if the patient is wincing or appears to be in terrible pain, please let the nurse know. You are part of the healthcare system when you are visiting your folks. And so we want you to feel empowered and have the agency to reach out and say, something's not right here, can somebody come? There's a call bell in every patient's room with a big red cross on it, and that's how you get the nurse. So please feel empowered to follow up if somebody is in distress when you're visiting. All right, okay. So if you make a home visit to a congregation member and nobody comes to the door, even though you know that they're there, what do? Is that a concern? That's a pretty big concern. If you know that they're there, but they don't come to the door, that would be a real red flag. So you might try the door, see if it's open, or if you don't feel comfortable doing that, then call a family member or call the person. If you don't succeed that way, you might even reach out to the sheriff's department to do a welfare check and make sure that that person is okay. We've had a number of folks come in the hospital who were down in their home by themselves for hours. And then when they didn't show up at work the next day, somebody called and said, this is not like him. Can somebody go check? And found them down there. So if they're acting strangely or slurring their words or seeming off balance, those are definitely red flags for a stroke. So we want to get them some medical attention immediately. If the person asks you to help them get out of the wheelchair, I would be very afraid of doing that myself. Now, Robin can do that easily, but that's not really my skill set. So unless I've been trained in how to do that, I'm probably going to want to find somebody else to help them do that. Well, a lot of this is really, again, understanding our limits. And every congregation has gifts that they can share with other congregations or with the community at large. And we all have limitations too. You know, some of our large churches have vans and buses that they could drive around and help with transportation. And some of our smaller congregations have different skills and gifts. And so that's kind of what our network is set up to do, is to help us to share in all of those gifts and spread them around. So a couple of things to do in taking an honest inventory of your congregation. Where are your congregation's gaps in providing compassionate care for each other? Some congregations have an inner circle known to everyone, while others may not get as much support. I think that's very common in churches. Some are great at providing compassion, but unskilled or unable to provide practical help, or the other way around. And some are great at almost all aspects of congregational caregiving. I've been in a church like that before. It's really wonderful. And then it's important to know how congregational care is structured in your congregation. Does the pastor really do it all? In a lot of churches in this area, that is the case because we are very small congregations. And so the pastor is kind of taking care of all of the business of the congregation. Another might be the pastor sends out an email blast to all the congregants and people respond as they are able. Or the congregation members know their various roles and they just go into action informally when they know about a need. And then it's a small church. Oh, the congregation has appointed or ordained lay leaders who are responsible for pastoral care. Or it's a small church and everyone always knows what the needs are. A lot of times that is the assumption that is made. And a lot of these do have gaps in them. I grew up in a fairly large church where there were deacons who were assigned like 37 families each or something, and so they were supposed to reach out to those families every quarter and make sure that they were doing okay and all of that. But even that has gaps. And people, again, have different skill levels. So there's no one right way to do it. But whatever way we're doing it, we want to make that work as well as possible and try not to wear out the pastor as much as possible. And then we might ask, what are the greatest needs among the parishioners? Education and training for them, structure to help organize and communicate the needs and utilize volunteers well. It might be support for people who are going through similar challenges, or motivations or friendly competitions to get healthier or to learn new skills. We have looked into doing some healthy competitions, friendly competitions between some of our different partner churches, just to kind of get us more active and fit. And so that's one way that we could support each other. So what does your congregation need in order to overcome the gaps and provide the high quality, spiritually based care to all of your parishioners? So that's just some food for thought to consider as you think about what your congregation's gifts are, what your congregation's needs are, and how you would like to participate on whatever level in AppFaithHealth. Larry mentioned some of the ways earlier that we are partnering with other organizations, and I'm really excited about our work with Appalachian State University. One of the community nutrition classes is assigned to 4 different congregations in the community, and they are meeting with those representatives from that congregation and learning what the congregation members feel like they need to know, what their congregation needs, and then they're designing programs to fit that. So it's really exciting, some of the partnerships we're able to do in the community. And Larry also mentioned our drivers program. There's lots of ways that we can all work together to help fill in the gaps, because there are lots of gaps in healthcare. Let's just face it, healthcare is not perfect, and there are lots of gaps. And so we're just looking for ways that we can learn from the congregations how we can do things better and how we can offer some of our expertise to help you do some things better. So, for example, our Safe Moves training, it helps people learn how to get people from a wheelchair into a vehicle, or from a walker into a church pew, and kind of trains them on how to help in a constructive way that won't harm a person. So every congregation has ways that they can support others, and every congregation has input that could be helpful for the healthcare system. And we really want this to be a two-way partnership. So in ordinary times, when it's not COVID, we have an annual breakfast for clergy and faith leaders, and we use that time to solicit your feedback so that we know what you're hearing in the community and in your congregations, because they're likely telling you things that they're not telling us. And so that feedback is really helpful so that we can learn how we can do things better in the healthcare system to support the community better. Right? Okay, so we've got a couple of success stories here. We had Andy at the Orthodox Church. He took on our first Tier 3 need by providing rides to a man who needed several follow-up visits to his surgeon before he was released to drive again. The man offered to pay the church, but they explained this was part of their outreach ministry. And in the end, the man told Andy that he told his son he was going to start going to Andy's church. And his son said, if you're going to go back to church, you should come with me to my church. And so the individual ended back up in church, connected to his family. Curtis Mull at Friendship Methodist Church had a funeral to conduct, and the 96-year-old sister of the deceased was deaf and needed a sign language interpreter. So we were able to put out a quick request to all of our partners and found, someone at Mount Vernon Baptist Church who was able, to actually provide that sign language interpretation for that funeral. So those are just a couple of, areas where we're all able to really work together. So, you've got a community health nurse at your fingertips. We've got an outreach person who is going to be helping in some of those. We also have the folks at Grace Lutheran who are performing kind of like a parish nurse. And so they are available to help us out some and to provide some of these kinds of consultations. We have education and training, and we also want to hear from you. So we don't have a formal survey for today, but we really want to hear from you what you feel like the healthcare system can do better and how we can support you in your ministry so that we can provide and help support a healthier community. So before we go, I just want to reiterate one other thing that Larry said, which was that chaplains are with patients for a very brief time. We have maybe one visit with them. It might be 15 minutes, it might be 2 hours, but basically we come and they come and go and they don't see us again. But the congregations are the ongoing support for these folks. You are there for their births of their children and grandchildren and for their baptisms and for their funerals and their families. And so you know these folks better than we do. And so it is a high priority for us that we communicate well with our congregations and their leaders. We want, I always ask, as Larry said, we're not mind readers. I always ask people, can I contact your pastor for you? A lot of times they'll say, oh, he'll know, when he might not know. And so I really, I don't push it too much, but I always make that offer because it's important to me that they have that ongoing support from their community congregation. So I just want to leave things on that note, unless there are any questions, or Robin or Larry, if you have something else you want to add.
Well, I guess I would want to say that, if you have any questions, we're always available, if you want to call us or email us, and we're happy to help anytime. So please reach out if you have a question.
Great. Okay. Well, thank you all so much for being here, and have a good evening.